Hello, everybody. Happy Thursday. Here we are again. Hello to everybody that is watching in the Clinical Connections Facebook group. Hello to everybody that is watching on Instagram. I hope you are all having a wonderful day so far. It's September, it's fall, sort of. I'm in Florida, it's still 90 degrees. We don't really get much of a fall down here. But I am happy to be here today with you talking about a very controversial topic in the rehab world. Today, we're going to be talking about manual therapy. So if you are a clinician, you either love it or you hate it, right? The research keeps swinging back and forth in support of it. Sometimes it says it's good, so use it. Sometimes the research says it's not doing anything, so don't use it. So today, what I'll be talking about is we're going to start with talking about the different schools of thought. We're going to talk about clearing up some of the confusion on this topic. I'm going to explain some of the best practices, the evolution of the research. I'm going to talk about where and when you can use manual therapy, and then I will share with you if and how I use manual therapy in my own practice. Okay, so my goal here today is to help you just kind of gain some clarity on this really confusing topic. Give me 1 minute. Check something here. So for anybody new that's here, I am Dr. Jody Miller. I'm a physical therapist and I'm a mentor to PT, OT students and new grads. I've worked in just about every setting that there is for PTs. I have worked in acute care. I've done oncology. I've done pediatrics. I've done home health. I have done a lot of outpatient. I've done a lot of skilled nursing. I have worked in multiple skilled nursing facilities as a clinician, and I was also a rehab director for a skilled nursing facility. And now I own my own cash-based practice in Florida, and I am the owner of Clinical Connections Mentoring, which is where you are today. So what I'd like you to do is, if you're watching live, please go ahead, type live in the comments and tell me where you're from. Tell me where you're from in the chat. If you are watching the replay, whether you're watching on Instagram or you're watching in the Facebook group, same thing, just type replay, tell me where you're watching from. And also, I want you to drop in the comments, what do you think about manual therapy? Just what are your general thoughts about it? Are you a fan of manual therapy as a treatment or not? Okay. So you may currently attend, or you did attend, a school that maybe didn't teach a lot about manual therapy, or you may currently are in a school or went to one that was really heavy on teaching manual therapy techniques. And because of either of these situations, you may either not use it all or you may use it every day. So you may have even taken it a step further and done your own research on manual therapy. And depending on how up to date you are with the research, this may also dictate whether you use it or not. I do want to clarify today, before we really get started, that when I'm talking about manual therapy, the only thing I'm talking about today is specifically joint mobilizations, manipulations, and neurodynamics. Okay, I'm not going to be talking about soft tissue massage. That's its own intervention. It has its own billing code. I'm not going to be talking about trigger point release. I'm not going to be talking about PNF, your D1, your D2 patterns. These are all separate interventions. Today, I'm strictly going to be talking about joint mobs, manipulations throughout the entire body, okay? So let's get started with the different schools of thought regarding manual therapy. One school of thought is that manual therapy is an effective treatment that gets to the source of the joint problem, whether that's pain or joint stiffness. That with our hands, we can move a joint in a specific plane of movement to decrease the pain or increase joint mobility or range of motion. The other school of thought is that manual therapy is nothing but a passive modality. It's way too reliant on a biomechanical approach, and we can't get deep enough to really have an impact at that joint level, right? That it's really impossible to move a joint enough to really improve the mobility of that joint. It's not helpful because the patient isn't actively doing anything. And since the patient isn't doing anything, there's really no benefit to this intervention. A third school of thought is that a combination of manual therapy and other interventions is the best recipe for treatment. Each of these schools of thought come from what you were taught in school, like you were saying earlier, right? So whether you learned a lot of manual therapy or not, and when you went to PT school, based on what the current research was at that time. Okay. And I think this is where a lot of the confusion comes from. Some people were taught by their professors and their CIs to use a lot of manual therapy and that it's an effective intervention. Some people were not taught any manual therapy by their professors or their CIs, so they're not comfortable with it. They don't use it, therefore, or they don't understand it, and therefore they don't use it, right? So this sets up the groundwork for someone who doesn't want to use it at all, right? Then on top of that, so what you were already taught or what you were exposed to in school or on your clinicals, on top of that, the research on manual therapy tends to swing back and forth like a pendulum, right? So in the early 2000s, the research supported manual therapy. Use it, it works, do it. Then research came out that said manual therapy is good, but it's best used with exercise, specifically all of the research that was done by Gail Dial. If you're curious, search Gail Dial's name, you'll find a whole bunch of stuff. Then in the 2010s, research started to say manual therapy is passive, doesn't have the same effect that we once thought it did. It doesn't even, you can't even target a specific area. Now the research is coming back and saying manual therapy is good, but it's not based on biomechanics. We have to consider the psychosocial layer and the person's pain classification, whether it's nociceptive pain, nociplastic pain, or neuropathic pain. You got to think about all those things when you're using manual therapy. Then we add on another layer to the confusion, and we have this wonderful thing called social media, right? Where everybody's free to put out their opinions out there for anyone to read. And to be honest, the loudest opinions tend to be the far extremes of both of those viewpoints that I've already talked about, right? You've got people saying manual therapy is terrible. It's purely passive. The research doesn't support it. And if you're using it, you're an idiot. And then we've got other people saying manual therapy is the best thing since sliced bread, but you have to use biomechanics to guide your technique selection. If you're not doing that, then you're not doing it right. Right. And I think this is what makes that pendulum swing even farther from one direction to the other, right? It's the ease of hearing or reading a water hose of opinions on social media. It's the lack of interpreting the literature ourselves. It's the constant debate across the entire profession on what is better. And it's that desire to make the simplest route to your decision making when you're in the clinic, which is simply to do what everybody else around you is doing. So if you work in a clinic that does a ton of manual therapy, all the other therapists there doing manual therapy, you're probably going to start to do it, whether you agree with it or not. Or if you work the other side of that pendulum, you work in a clinic that nobody touches a person, everybody does Therax or what else, but there's not any hands-on treatment, you're probably going to fall into line with that, even if you think manual therapy may be beneficial for your patient. And I'm not saying that every clinician does that. I'm not even saying that you do this, but it is very easy to fall into practice of doing what everybody else is doing versus doing what is best for the patient. Okay, so we've got research, right, that has to focus on limiting the variables in order to prove something, right? You can't have a research study that's looking at a whole bunch of different things at once. In order for the research to be effective, it's got to limit all these other variables. But variables are really, really hard to control in people that have emotions and they have past experiences and they have expectations, right? And research, so when you can't control for all these variables, that all these layers that actual people have, like emotions or past experiences, trauma, whatever they have, you can't control for those things if you're testing for manual therapy itself, right? On top of that, research is constantly changing as we learn new things, which is it's supposed to do. As we learn new things, we now study new things, right? What we know now is more than what we knew then, right? So that research is constantly changing. And that is where we have that pendulum that keeps swinging back and forth and leading to confusion. Then we've got really, really loud people with really strong opinions constantly telling us to believe or do one thing. And if you don't believe what they're saying or doing what they're saying, then you're stupid, right? You kind of feel that, right? But these beliefs from these really, really loud, strong, opinionated people are rooted in their own beliefs, right? And on top of all that, so we have this constant change in research because we're learning new things and we can't really control for every variable of a person. We've got really, really loud opinions from people. And then we don't have enough time, sometimes and not enough energy to develop our own thought processes. So the result is confusion, right? So I'm not here to tell you what to do when it comes to manual therapy. I'm not going to tell you to do it. I'm not going to tell you not to do it because I truly believe that it should be based on the patient that's in front of you, what they need in that moment, their perceptions of their situation, and their current pain experience. That's how I decide if and when I'm going to use manual therapy. Okay, so I'm not going to tell you to use it. I'm not going to tell you not to use it, but I will share how I use it. I do use manual therapy, but I don't use it with every patient that comes into my clinic. I have patients that I do a lot of joint mobs with. I have patients that I don't use any manual therapy with. I have patients that I'll sprinkle it in based on what they're telling me in that session. But I will say most of my patients will get a small dose of those manual techniques kind of at the beginning of their session, maybe the first 5-10 minutes. And then we end with a lot of active movements and a lot of exercise. I use manual therapy mostly to reduce pain and occasionally to increase that range of motion. I do a lot of my joint mobs at end range of motion, whether that range of motion is limited by pain or mobility, because that's where the problem is, right? That's where the limitation is occurring. So that's where I'm going to provide that treatment. I do not do joint mobs in the open pack position. I'm not really doing anything there. I do the manual therapy technique where the problem occurs, where that limitation is happening. So, open pack for shoulders 90 degrees, but if they can get their arm to 120, why am I doing it at 90? I'm going to do those joint mobs at 120 for a little bit of time. Okay. I don't care about the biomechanics of the joint that I'm working on. I don't care. I just want the joint to move. Any movement or mobility to the joint is really going to help the patient with the pain and the range of motion. Okay. Don't really care what direction, I just want it moving. I have used manual therapy in every setting that I've worked in. I've used it in acute care, had a patient complaining about knee pain. Let's go ahead and do some joint mobs, see if it helps you walk better. Okay. I've used it in home health, used it on total knee replacements and skilled nursing, used that one a ton. A lot of total knees and skilled nursing, right? I would do joint mobs to help decrease their pain so we could do more standing tolerance activities, right? I've used it in outpatients, certainly with all my athletes, general orthopedic patients, and I've used it for patients with neurological impairments, right? Patients aren't neuro or ortho, patients a whole body, right? So I've had patients come in with neurological impairments. I might have done some ankle mobs to improve their dorsiflexion range of motion. Then on top of that, we're going to do active dorsiflexion, right? I was taught by a fantastic orthopedic professor who was a manual therapy fellow. So I learned every manual technique that was current at that moment, to the point that every ortho continuing ed course that I attended in my first year as a new grad was all a review. I didn't learn one new manual technique in that first year because she had already taught it all of it to us. But on top of that, yes, we were manual heavy, but she also really stressed the importance of doing manual therapy with exercise, because that was the current research at the time when I was in school. And that is how I practice now. Okay. I do also use a lot of mobilization with movement. So I'll provide joint mobs with active movements while I'm doing the joint mob. So some examples would be doing an anterior glide to lumbar spine while the patient is doing prone press-ups. Right? Still doing manual therapy, but I've added activity to it. The patient is no longer passive, patient doing something active. Same with an inferior glide to the shoulder while the patient's doing active shoulder abduction. And I've also used it a lot with, more commonly, sciatic nerve glides. So I'll hold the glide or hold a hamstring stretch and then have the patient do active dorsiflexion for the glide. So they're doing the glide, it's not a passive glide. Okay. So all this to say, that I don't think manual therapy is a should or shouldn't in PT practice. Actually, there are very few things in PT or rehab altogether that are should or shouldn'ts. I think it is entirely dependent on what each patient needs. It can be helpful for some people, it can have no effect on other people, right? So here are my final thoughts. Biomechanics aren't really necessary in the use of manual therapy. Just get the joint moving. The direction that it's moving doesn't matter. Manual therapy is not ideal for an entire treatment session to consist of manual therapy. Ideally, manual therapy can use initially to decrease the pain and is best used when in conjunction with exercise and education. Okay. The amount of manual therapy used during an entire plan of care should really, ideally, will decrease over time, right? So you may start when you, let's take a frozen shoulder. I'll give you an example of a patient I had. Frozen shoulder. She wasn't given the diagnosis. She had shoulder pain. She was actually going to another chain clinic in this area, had been going there for months and had no relief in her shoulder pain. And because of that, she ended up having a frozen shoulder on top of just shoulder pain. She came to me. Initially, I started with a lot of manual therapy, probably 30, 35 minutes of manual therapy because she was so limited in her active and her passive range of motion. So I did do a lot initially, right? But as we progressed, the amount of manual therapy that I did significantly decreased. And by the end, we were doing nothing but Therex. She got her full range of motion back within, I think it was 2 months. She had full shoulder range of motion back together, no more pain, completely different person, right? So the amount that I did decreased over time. Another thought is that mobilization with movement is a really, really good way to incorporate active mobility with joint mobilization. So you got those people saying, oh, don't do manual therapy, don't do joint mobs because it's purely passive. Not if you make it a mobilization with movement. So you can still do that joint mob and then have the patient actively participating in that intervention, okay? Patients are not robots that move mechanically. There's certainly more to a patient, like their expectations, their previous experiences, and all of this will play into their response to manual therapy. If someone has had a good experience with manual therapy in the past, chances are they're going to respond to it. If someone's not had a good experience with manual therapy, probably not going to be the best thing for that patient, right? The source of their pain experience and their pain classification will impact how they respond to manual therapy. And this comes from an article in JOSPT last month, so August of 2023. They're still doing research on manual therapy, and now they're understanding that a patient's response to it will be dependent on their pain experience and their pain classification, right? All research should be interpreted with a grain of salt. Research should not be an absolute. Research should be used as a guide because of what I talked about earlier, right? Research has to control for so many variables, how many people, how many patients actually control for all those variables, right? Every person is different. Every patient that comes into you is different. They have different expectations, different experiences, different pain classifications. So use the research, read it, take it with a grain of salt, and it should be used as a guide, not an absolute. Try not to follow what one person says or what all the other clinicians around you are doing. Simply just do what is best for the patient in front of you. Okay. I hope this information was helpful for you. I hope it cleared up some of the confusion, or at least maybe helped you understand why there is confusion around manual therapy. I hope you have a better idea of it, of if and when and how you want to use manual therapy in your own program, in your own practice. I hope that was maybe cleared that up for you at least. If this is still a shaky topic for you, or you want to learn more about how you can use manual therapy in your practice, feel free to reach out to me. Send me a DM. Manual therapy, clinical reasoning is just one of the areas that I really enjoy talking through, guiding new grads, even seasoned clinicians, to improve or become more effective with in my complete clinician mentoring program. Okay. So by talking through specific cases and examples, you can bring them to me, bring these specific cases, your clinical reasoning, your decision making will improve. So send me a DM, drop complete in the comments if you want, and let's chat about how I can help you either figure out if manual therapy is something you want to do or is best used for a specific patient that you have. Okay. I'd love to help you figure out how to do it, how to make it easier, right? I hope you learned something new today. Please go ahead and drop in the comments your aha moments or something that really stood out for you or something new that you learned today. I want to thank you for watching, whether you're watching on Instagram or if you're watching in the Clinical Connections Mentoring Facebook group. If you have any questions about what I talked about today, again, like I said, feel free to message me or drop your questions in the comments. I will certainly come back and answer any questions that you leave there. See you next time.